Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders.
What's up?
What a team we have tonight. I'm Justin Burke, joined tonight by Dr. Chris the Chu Manchu and the wonderful producer, Crystal Nora. Crystal, how's it going?
I'm matched for fellowship. I'm so excited. Keep going on, Cribsiders.
Incredible. Congratulations to you. To anyone else out there who matched or didn't, we love you and hope everyone is doing well in this major transition. It's a very exciting time in medicine. But speaking of transitions, we had a great episode tonight. Our guest tonight, Dr. Ignacio Tapia, here to discuss obstructive sleep apnea. But before we go into that topic, hey, Chris, can you tell us about the show?
Sure. We are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer and linking questions about core topics in pediatric medicine.
We have a great conversation with our guest, Dr. Ignacio Tapia. He's the Division Chief of Pediatric Pulmonary Medicine for the University of Miami Health System and Jackson Health System. His main research interests are the pathophysiology and treatment of obstructive sleep apnea in children. He teaches us about the risk factors, screening, diagnosis, and the treatment of OSA. And why when Chris's children kick him in the face, it might be because they need more iron. You won't want to sleep through this conversation about OSA.
Dr. Ignacio Tapia, welcome to the Cribsiders. Thanks for coming on to the show.
Thank you very much for the invitation.
We're a pretty informal group. We call everyone by their first name. I hope that's okay. Is it okay if we call you Ignacio? Beautiful. You can call us anything, first name, or if we get a nickname by the end of the episode, that works. Bud, yeah, Tiger. We would love to get to know you a little bit better, and our audience would love to get to know you a little bit better. And so can you just give kind of a brief introduction, maybe kind of like a one-liner to our audience to say who you are and maybe something that you're interested in outside of medicine?
Yeah, absolutely. So actually, I was born and raised in southern Chile. I went to med school there, and then I moved to Santiago, the capital of Chile, to do a residency in pediatrics. And after that, I moved to the United States, to Philadelphia, to do fellowship in pediatric pulmonology, which at that time you could, having trained somewhere else. And when I finished, then I decided, actually, I had to either go back home, or if I wanted to stay here, I had to do 2 years of pediatrics residency to be board eligible. So I selected that one, and I did 2 years of pediatric residency. And after that, I sat for every board on earth, and I became an attending at Children's Hospital of Philadelphia, where I trained, triple certified in pediatrics, pediatric pulmonology, and sleep medicine. And right now, recently in July, after considering the years of training and attending, like 7 years in Philadelphia, the only city I have lived up to that point in the US, I moved to Miami, and I became the division chief of the Division of Pediatric Pulmonology at the University of Miami. So it's an entire change for my family, and it's been great.
That's amazing. And like, what amount of training I'm sure you have gone. I bet pediatric residency training was like very, very easy for you after all the work. But Santiago is an amazing city. Where I've been because I did what a lot of millennials do and have an existential crisis and go hike Machu Picchu. What a beautiful part of the country.
Yeah, absolutely. You need to go to southern Chile.
Yeah, it was wonderful. Crystal, one of you have a question?
I'm thinking you go, Crystal.
So one question that I do have is, what was the last best thing that you ate? Like a meal that really sticks out in your mind?
Well, actually, we cook at home. So it may have been something really recently. We do homemade pasta, homemade pizza, and all that sort of stuff. So here we're going to a farmer markets, and you know that Miami is tropical. So in the wintertime, you get a lot of the produce that you could get in Philadelphia or in Baltimore in the spring. So now is the time of tomatoes, kale, and all that sort of stuff. And we did homemade pasta fettuccine with kale in the dough with a sauce of fresh tomato and cremini mushrooms. It was amazing.
Oh, Wow. I wish I ate dinner before this. This is great.
I'm really hungry too, so I'm with you. The question I often ask is, what's the best piece of advice that you've ever received, either as a learner or learned somewhere else?
As a learner, I didn't receive this piece of advice. It's something that I learned myself, was to approach learning from a fearless perspective. Because it's very daunting. When you go to an intense academic institution, for example, such as the case of Hopkins or something like that, and you look all these accomplished people, or you're just starting, you think, I will never be able to do it. It's so much effort, and etc., etc. But then I learned that you need to take one step at a time, and you're gonna get what you're gonna get if you're driven by passion. That's what matters, and to do stuff that are really important to your heart.
I love that so much. I feel like there's a certain aspect of just trusting the process, keep pushing forward, and doing what you love.
And in the process, because nobody was born an adult, nobody was born a physician or whatever. It's a process. So you go through the process, and I'm a truly believer, and I say that to my trainees as well, that we're all in training, but in different level of training. It's nobody that finished training ever. I mean, we don't. We are learning every day.
Lifelong trainers.
Yeah, and
lifelong
we learn
trainees.
From people that actually maybe way younger than you and have less training. You learn stuff from them. I learn from the students, from people who are ahead of me. So
that's such a core part of, I think, our ethos of the podcast is constantly learning from not only experts, but from people in all levels of training from our program. I have certainly been part of this. I've learned a lot from med students. I've learned a lot from residents. Yeah. I learned one or two things from Chris, but I think overall, it's been a really good learning process.
Hey, Cribsiders listeners, we're back with another sponsor. This is all about Freed. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Freed was built for clinicians by their significant others. Gabby, a family med physician, and Erez, a computer engineer, are married. Erez built Freed so Gabby could stop charting over the weekends. It was one of those selfish presents that you secretly get for yourself. Freed is an AI scribe that does your medical documentation for you instantly. Freed listens, prepares your notes, and writes patient instructions. Charting is done before your patient even walks out of the room. Freed learns your style over time, just like any human scribe, and most importantly, it is HIPAA compliant. So you can try 10 notes for free, and after that, it only costs $99 per month. Better yet, Cribsiders listeners can get $50 off that first month. So try Freed for free right now by going to getfreed.ai. That's GETFREE.ai. And listeners of Cribsiders can use code CRIB50 for $50 off that first month.
Speaking of learning, let's dive into some content, because I am excited to really take a deep dive into our topic today of obstructive sleep apnea. And so, Crystal, do you want to kind of kick us off and get us started?
Absolutely. So we're actually in clinic today. We're seeing Cece Parker. She's a 4-year-old who's brought in by her mom's for her annual well child. Her mom says that Cece is generally a playful child, but they've noticed an increase in irritability over the past few months. One parent remarks, she just seems groggier in the morning and just naps a lot, especially during the day. And so first question is, how do you think about patients who present with OSA? So maybe starting with, how do you define obstructive sleep apnea? And when do you start to think about it when patients present?
Yeah, so there are two things, because one, for the case, I wouldn't necessarily think about OSA immediately. But in general, people present with OSA, the cardinal symptom that children have, about 50% of them is snoring. So parents report snoring, mouth breathing during wakefulness. They also report pauses in breathing, like apneas, but they don't report it like that, and gasping for air. Now, since pretty much everybody has smartphone, many times they show you videos in your sleep, so they can help you guide, okay, it looks like the person is clearly obstructing and having trouble breathing at night, and then they will prompt us to do something else about it.
And my understanding too is a lot of the presenting symptoms can be related to trouble functioning in school-age children, or almost like an ADHD type picture. Is that like the irritability and things? Are those things that you're seeing commonly, Or is that kind of a myth and not really a common presenting symptom?
No, that is correct. Actually, in school-age children, actually even in preschool children, you see deficit in executive functioning, which is like following orders or dexterity with the hands, for example, things that you can test, like ADHD-like symptoms. And in one of the seminal studies already like 20 years ago that Dr. Gozal did, they did some questionnaires about sleep, if I remember correctly, and the children that had like mild to moderate ADHD symptoms, they went to have sleep studies, some of them, and those who had obstructive sleep apnea and got treated got way better. But those who had like super severe ADHD symptoms, it wasn't so much related to OSA. But it can give you that type. And also in children, it's more frequent that they are irritable than sleepy. Like teenagers, they get, and adults, sleepier and things like that. But in the young kids will be the other picture.
So, we've already thrown the word out, this sleep apnea word out. Can you sort of define that a little bit? Like if I was a parent bringing my kid in and, I've heard sleep apnea, sometimes I think of, my overweight uncle who falls asleep on the couch all the time and doesn't wear a mask that was given to him. I think sleep apnea. What exactly is sleep apnea and how does it happen and how does it happen in kids versus the way I think about it in adults?
Well, I love the question because I will tell you, but this is trademark, the way I explain it to parents. And it's very successful. I say, imagine to the parents. They say, what is it? I don't get what it is. So this has evolved through my career. I started telling them, this is a collapse of the throat. And then I realized nobody was picturing what it was. Okay, so now I say the following. Imagine you're sleeping quietly, super happy. And I come up with a pillow and put it on your face with pressure like this. What would you do? Tell me, what would you do? So the parents say, well, I will fight it. Yeah, and what else? I will try to remove it from the pillow from my face so I can breathe. And what will happen? Let's say to your heart rate. Well, it will go up. Would you feel like quiet? Would you feel stressed? No, I would feel stressed trying to get rid of it. I say, well, that's what happens because actually we want to open up our upper airway so we can breathe, to remove that pillow. So exactly what you're telling me, you won't be able to breathe because I'm holding the pillow there, so your oxygen will drop, your heart rate will go up, your blood pressure may go up, you have all this sympathetic stuff, and this is happening, let's say, 10 times per hour, 15 times per hour, night after night. Is very cumulative, the things that are going to happen, you are not going to get restful. And I say, and that's apnea. So yeah, everybody understood. And the other thing that kids have is something that we call hypopnea. That is not a total blockage of the upper airway. So imagine I just put the pillow on your face, but without pressure. What will you feel? They say, well, I will try to breathe and etc., etc. Maybe I feel, well, some parents will know better, that I'm sort of rebreathing the same air, which happens. So they may accumulate carbon dioxide, for example, and things like that. And with that, I feel everybody understands it.
Well, I was going to say, but I could see my little patient say, well, how come I'm not walking around with a pillow on my face when I'm awake?
That's another excellent question because that's why it's called obstructive sleep apnea and not obstructive wakefulness apnea. So it only happens during sleep because you lose certain controls of your muscle tone. So then I said, when you go to sleep, for example, or you have seen your child going to sleep, how are they? Or a puppy for the kids. Well, they're very relaxed, etc. Well, that happens at all the levels of the muscles. And they're also something that happens when we dream, which is the period that we call REM sleep, that we're basically paralyzed except for our eyes and our diaphragm. And it's supposed to be a mechanism of protection, so you wouldn't be reenacting your dreams like you're Spider-Man or whatever Marvel superhero that would be around or whatever you want to be dreaming, right? That's a disease that you guys who treat adults see, but in kids we don't see it. So when that happens, you are more prone to have obstructive sleep apnea because all the muscles are really floppy. So if you have any stress in the upper airway, a load, for example, like enlarged tonsils, enlarged adenoids, or people who have different facial structures, right? Like they have an upper airway that's smaller because of facial structure, like craniofacial anomalies, or kids with Down syndrome, or etc., then they're more prone to have obstructive sleep apnea.
The obstruction, it sounds like you mentioned, are things like the adenoids, are things like maybe a deviated septum or facial abnormalities associated with certain genetic sequelae. But the pediatric anatomy is more prone to very specific obstructions like the adenoids. Is that the normal major cause of sleep apnea?
Yeah, what we see mostly is adenoids and tonsils. However, the studies that have been done with MRI showed that the correlation between the tonsils adenoidal size and the apnea-hypopnea index, the obstructive version of the apnea-hypopnea index, is about 50%. So only 50% you can explain by that. So it's a combination of anatomy and function. And many times when I am with the trainees and we see kids, for example, with tonsils that are kissing, like grade 4, and we say, do you think they will have OSA? I say, yeah, okay, let's bet. And it's a toss of a coin, because many of them will not have. And then, on the contrary, you see kids with rather small tonsils, but they have a ton of symptoms, and they do have OSA, because it's a matter of anatomy and function. Another question that actually not a parent asked me, one intern asked me one time. They call and they say, when I talked to you, because the child was admitted with obstructive sleep apnea, ENT cannot do the surgery now because they're having a concomitant viral infection and the CPAP device has not arrived. And what do we do? Can the child die overnight? And that would be really rare. I mean, it can happen, but very, very rare, because our physiology doesn't let us go apneic forever, right? Eventually you wake up and then you will breathe, or you have what we call an arousal, that you're not totally awake, but your brain arouses if you want your brain awake and let you breathe. So that's what would happen in kids. So that's another question that families have, because typically by the time that they get to me and they get diagnosed, it's not that they started having OSA yesterday. Most likely, that they're telling you, it came to the attention of someone for months.
No, and I think I imagine that's very scary for a parent to witness and see. And so I love, you mentioned the kissing tonsils, might be a risk factor. It doesn't guarantee that the patient's going to have OSA. And I imagine certain of the specific facies associated with genetic syndromes are risk factors. What are other major risk factors for pediatric obstructive sleep apnea? Are there core things where it's like these other things that we should be thinking of someone being at risk for OSA?
Right now it's obesity as well. The obesity epidemic in the past 10 or 15 years is getting worse. So we see more and more kids who are obese and who have obstructive sleep apnea, because typically, you gain weight and you will see some fat deposits typically in your belly, love handles, things that you see with your eyes. But also you have fat deposit in other places that you don't necessarily see, such as your tongue, for example, your palate. So your upper airway becomes smaller due to that. So those, and then the big cases of the kids with craniofacial anomalies, there are many of them, genetic syndromes, and also kids with achondroplasia, for example. Anybody who will have mid-facial hypoplasia will end up having more restricted upper airway, and then more difficult to compensate for that.
And so maybe can I ask one more question on this before we go to the next? Is what about age distribution? Are there specific ages where most pediatric patients present with these symptoms, or is it really throughout the child's lifespan of where it gets caused?
The symptoms of the obstructive sleep apnea.
Oh, interesting. Both. I assume that they would somewhat correlate. Yeah, maybe primary cares are really delayed.
The symptoms in the small children many times are snoring, or as you mentioned, irritability or ADHD-like situation. Behavioral problems, not being able to follow instructions. In the adolescents, it's more like the adult sort of thing, and they're sleepy. They fall asleep because actually interrupts the sleep architecture and things like that. A sleep architecture, which means the different stages of sleep that we have to go through the night, are preserved in children. Children have obstruction back to back, and they don't have a lot of disruption of the sleep architecture for most of the time, which is supposed to be also like a protection mechanism. We try to do bad things, but luckily our organism has our back, and physiology is there to back us up. So that's good. And in terms of presentation, typically, for example, the sex distribution in prepubertal children is pretty much the same. The incidence between boys and girls is pretty much the same. And the main incidence that we see is between 3 and 8 year old, which is the time that the tonsils and the adenoids start to grow more. And then you have another peak in teenage years, which is mostly related to obesity. In teenage years, though, males have like 2 to 3 times more OSA than females, and that goes until menopause. And after menopause, they equilibrate and they have the same.
I think that's a really helpful walkthrough of what to be thinking about at different ages for folks who are presenting to our clinic with, these signs and symptoms of OSA. And I think for me, that brings me back to our patient is that you're, taking a sleep history, you're finding out from the family that our patient CC is snoring and that there's concern about some apneic events that are happening. Maybe family has brought in a video that they're really concerned about. And we're looking through her chart, we're noticing that she's in the 99th percentile for weight, 87th percentile for height. You're trying to piece this together. And as a learner, one of the questions I have for you is, how do you take that good sleep history? What kinds of things are, going through your mind when you're thinking about, I've got a patient, I'm concerned about their sleep. What questions should I be asking in clinic?
Yeah, it's very important to start with the bedtime routine. Because whenever we have someone with sleepiness, for example, we want to know, are they actually sleeping what they're supposed to be sleeping? All of us, we have done a lot of shifts, right? Like 30 hours, whatever hour. And it's not the same when you have a good 2 nights of restful sleep versus when you are post-call. You are immediately like a different person, right? So that matters. So we start with the sleep history, and that starts with the sleep environment. For example, in the case of young kids, what time do they start preparing to go to bed? What's the bedtime routine? Typically, kids do have a bedtime routine. It doesn't need to be so elaborated, but what they do, what time is lights out, what time that the kid fall asleep, and in the case of young children, something very important is whether they fall asleep independently or not. It's not important for the case of OSA, but actually it's important for us to know for sleep hygiene, because many times, normally we wake up about 1 time per hour. We don't remember the short periods of waking, and we tend to fall asleep with the same situation that we fell asleep at the beginning of the night. You want the pillow on certain side, you sleep on your side or your back, whatever that is. So for example, if the kids don't fall asleep independently, they are in the lap with the parents or with the bottle, they will wake up in the middle of the night and they will want the same situation. They cannot verbalize. They cannot say, hey mom, where's my bottle? They will be crying and irritable, and it's another situation that we see that is sort of an insomnia, lack of perspective. So we ask that. We also ask a lot about their night wakings and what do the families do with the night wakings, how do we attend to that. Then what's the typical time of waking? And also we ask whether they do take naps, scheduled or unscheduled, and whether that changes between the weekends and weekdays. That's from the behavioral perspective that we typically start with that. And then we go with the respiratory symptoms. So we typically ask about snoring, and actually it's important to know it's something that is occasional, for example, when you have a cold, or is most of the nights, let's say more than 3 times per week. Then we also ask about labored breathing during sleep. That can make us think about paradoxical breathing. And paradoxical breathing is when your chest and your abdomen are contracting asymmetrically. And why are they contracting asymmetrically? Because right now, I know this is a podcast, but we're here in video in the moment. So the 4 of us are going to take a deep breath all together and blow it off. Okay, so what you just did, right? Your chest and your abdomen move together, and that causes an increase in your airflow. Everything went together and symmetric. We took air in, we took air out, and everything moved together. When you have an obstruction, we again are trying to overcome that obstruction. So to do that, and successfully so, the abdomen starts to contract differently than the chest to make more negative pressure with the hopes of distally to open the airway. However, the upper airway is a muscular tube, it's not a bone. So imagine that you have a straw with a muscle, and I'm pulling from here with negative pressure, will further collapse it. I will not open it up. That's a very complex physiological concept that I need to explain on a video. So it's a different set of skills. But anyway, so that's why we ask labor breathing. We want to know where the paradoxing. Having said that, small kids paradox normally because the chest wall is more compliant. So, but let's say in older kids, you wouldn't, any of us, we shouldn't be paradoxing. Or let's say kids that are older than 3 or 4, they shouldn't be paradoxing that much. We ask for that. We ask for pauses in breathing. We ask for gasping for air. if they have seen that, like, and when you're a pulmonologist, you have to do all the noises. So most of the time I have to do the noises. And they say, oh yeah, okay, they do that. We also ask for nocturnal enuresis in the kids that are past the age that is normal, because that's also a symptom that is associated with that. For morning headaches, that can point out of retention of CO2. Basically, sort of those are the questions that we ask.
And can I ask, are you giving a pretty comprehensive behavioral and respiratory history for anyone that comes into your clinic? Or are these really people who are just saying that they're having trouble sleeping or having some, I guess if we have a patient, like Cece, and the complaint is that there's some snoring and some irritability, when you go through like the bedtime routine and learn that, maybe there's not a great bedtime routine, and so let's try to implement that. Is that kind of the first step, or are you doing all of this while also kind of pursuing thoughts about how should we be screening and diagnosing for obstruction in OSA?
Both, because what happens that, and we're going to get to that point, unfortunately, most likely Cece will not have a sleep study tonight on the day that she sees me, right? So there are things that we can fix in the meantime, because, for example, if the bedtime routine is a little out of whack or is non-existent, or one night is at 8 p.m., the following at 9 p.m., there's lack of consistency. There are things that we can arrange to ease also her transition when she comes to the lab. And to remove some symptoms that may be out of the way, because maybe you were telling me she's sleepy, but maybe she's not sleeping the hours that she should. So it's something that we can work on while we do the other diagnosis. But pretty much for a sleep history, everybody will start with the behavioral sleep first. At least it's the way that I train and I teach that way. So you get to know a little bit more what's going on.
That makes a lot of sense. And so let's say that we have a couple low-hanging fruits of things where we can implement working on a bedtime routine. But when we do talk to Cece, when we see her in clinic, again, we confirm that there are some witnessed apnea, that Cece is snoring. She's above, 99th percentile for weight. She has kissing tonsils. Maybe she has the risk factors that we talk about. And so we're thinking high suspicion for OSA. What are your next steps? Are there other things that you do to screen for OSA? Is there lab work? Is there an equivalent to like a stop bang score where we should be quantifying the risk? Let's say, what are your next steps for someone that you're sensing, if you were a betting person, you'd put a nickel down on OSA?
Yeah, in my case, when they already can refer to me, I will order a sleep study. In the case of a primary care pediatrician, I think you can do, because you have like 15 minutes to screen for many things. So obviously it's unfeasible that you screen for everything at the same time. But it's something that are low-hanging fruits, as you mentioned, and they could use the pediatric sleep questionnaire, the sleep-related breathing disorder part. There are not that many questions. That's something that the parents can do now. Everybody has EMR, so you can do it while they're waiting. If they have a greater than 0.33, it correlates really well with moderate obstructive sleep apnea or so. So you will know that someone that you can prioritize, for example, to have sleep study versus the next person who has a lower score. You wouldn't. There are other, that's a symptom questionnaires. There are other questionnaires that are based on quality of life related to the disease, and one of those that has been used in pediatrics successfully in research, for example, and also in the clinical practice, is the OSA 18. There are 18 questions that the parents respond about how they presume OSA can affect the quality of life of their kids, and also has some scores. With that, it can guide you to decide who you're going to refer to the next step if you have limited resources.
I love it. And any lab work? Are we checking for elevated hemoglobin or anything like that? Are there other lab findings that might be worth? At
this stage, not necessarily. I mean, if you are really concerned that maybe someone who's hypoventilating all the night, you can do a BMP, look at for example, how the BMP works and things like that. But from a clinical perspective, I wouldn't necessarily order a lab now. Same, for example, with EKG, that if you think they're going into core pulmonale or things like that, extreme cases that actually we do see sometimes, typically we order those with the results of the sleep study. Basically, because it's a better use of resources. Now, if you're in a clinic where you can do all that, honestly, I don't see any reason why you shouldn't. But
And I think that takes us into how do we confirm this diagnosis of pediatric OSA? And so we've talked a lot about sleep studies. And so I was hoping that you could maybe talk to us about home sleep studies versus going into the lab for a sleep study, thinking about what does a sleep study entail?
Yeah, so the sleep study is the gold standard. The in-lab attended. The sleep study is the gold standard for the diagnosis of obstructive sleep apnea. There are many other things that have been done with less success. One of those are the questionnaires. All are good at screening. For example, something that has been used also is the pulse oximetry, the nocturnal pulse oximetry, and then you apply different algorithms, and it's good for screening as well. All of those things that we use for screening have typically a good positive predictive value, but the negative predictive value is sort of so-so. So you have to be with a grain of salt. But those that are really, really positive, for example, most likely they have obstructive sleep apnea. For example, if you do the pulse oximetry and they have desaturation in clusters, granted, it's not someone with a pulmonary disease or anything like that, overnight, and the story is consistent, you could assume the person has obstructive sleep apnea. But the gold standard is still the in-lab attended polysomnography. That study is a very intensive study. It's very nice though. You have a lot of information on physiology. So it's 16 channels. It includes EEG channels. So you put 6 EEG leads, frontal, central, and occipital, 3 in each side, so it's 6. Also, you have the leads in the eyes to measure the eye movements. You have a lead in the chin to measure the muscle tone in the chin, because when you have REM sleep, then this drops because you're almost paralyzed. You also have a belt in your chest and in your belly to measure the movement of the thorax and the abdomen that we did, for example, when we took the deep breath. You will see all that in the plethysmography, that is called the belts that you put. You also have pulse ox. You have leg leads to mention to look at the movement of the legs, for example, periodic leg movements, restless sleep, that sort of things. And everything is also video recorded. We also measure end-tidal CO2. That is an excellent measure for ventilation. It gives you breath by breath the values of end-tidal CO2. And in some kids who are younger, and end-tidal CO2 may not be reliable, by the way, when your respiratory rate is greater than 20 or 22, because it needs certain time to plateau. So in infants that have a respiratory rate of 30 or so, we use as a backup transcutaneous CO2 measurements. That are good, but they're not as good as end-tidal CO2 because it's an average in the capillary that is measured. It's not breath by breath. It gives you a trend that typically lags like 3 minutes behind the end-tidal CO2. But when it works really good. Basically, that's it. And with that, off to sleep. So the first question when I tell that to any parent, they say, I know my child will not sleep. And I'll tell them, they will. They will, because they're just tired, they will. And also because the environment and the techs that we work with typically are very child-friendly. So we try to do this in a very child-friendly way. So they go to sleep, and then the following day, the study is scored by the technologist, and once the study is scored, we, the physicians, go and interpret it and agree or disagree with the sleep architecture or the respiratory events, and etc., and come up with a diagnosis. That's the in-lab. Home sleep apnea testing has not been approved in the US for children. And this is in the process of being reviewed, because now there's a new panel looking at this. The American Academy of Sleep Medicine, several years ago, they had a task force to see what would be the use of home sleep apnea testing in children. At that time, at the time of the publication, that's already some years old, they concluded that there was no enough data to back this up in children. So, as in the US health system, unfortunately, is driven many times by insurance companies. So that means that insurance companies will not pay for it because it's not backed up by the American Academy of Sleep Medicine. And therefore, in children, it's very difficult to do it because you may not get reimbursed. And no health system would be like super happy to say, yeah, do a lot of stuff, but don't get reimbursed. And, so that's what happens. Now, the good news is that with colleagues, at the time I was in Philadelphia, we did a study of home sleep apnea testing in children and youth with Down syndrome, because they are a special population, that they have a high prevalence of obstructive sleep apnea. And many times the families report duress in the labs. Many labs are not used to individuals with developmental disabilities and things like that. So we did the study, and actually we found excellent correlation with what we did. And now we're doing a randomized control trial, including typical and atypical neurodevelopmental children that are with typical or atypical neurodevelopment, to see what would be the use. And a new task force is set in place in the American Academy of Sleep Medicine. I'm confident that eventually it will get approved for children. Now, is it for every child? No. Some children, for example, those who require supplemental oxygen, those that are little babies, those that are very complex, as we see in pediatrics, I think that they will still be better served in the lab. However, a child who doesn't have any other complication may have Down syndrome, for example, but doesn't require supplemental oxygen, or etc., could safely have a sleep study at home if they're somebody a little bit older, I would say 5 or 6 or older, with no problem. But that hasn't been approved yet, but that's the future.
Can I ask, you mentioned a lot of these mechanisms that are in the in-lab polysomnography of end-tidal CO2 and the belts, and there's so much data, it seems, that's in a full sleep study. Maybe even taking a step away from OSA, can we go through some of the metrics that maybe a primary care doctor should feel comfortable, briefly looking at and understanding? And I think part of that is also seeing what are some of those other numbers and how do they provide insight into other sleep disorders or other parts of the data that kind of test can present?
Yeah, that's a great question. As you said, there's a lot of data. We interpret the study epoch by epoch, and every epoch is 30 seconds. So imagine through the night. It's like it goes forever. It's really exquisite data that you have there. So the first that comes is the sleep architecture, meaning how long did it take for you to sleep, whether you hit different stages of sleep. And that matters because in children, for example, obstructive sleep apnea is most frequent during REM sleep. So it could be that maybe you didn't have a lot of REM during that night, and if your study is normal, it could be that maybe it was normal because you miss a big chunk of REM and then you will have back-to-back events. But if your study is super abnormal and you still have little REM, most likely it will be even more abnormal. So we could say, okay, it's a way of interpreting the data. So I will take a gross look at the sleep architecture and see there if the definition meets the normality criteria. Typically, the report will say the sleep architecture is normal because this or that, or is abnormal because the person had less REM sleep or this and that. Also matters the arousal index. Typically, we want the arousal index in children to be less than 15. So you get to see how often did they wake up and whether this arousal index were spontaneous. That can happen in a new environment, or they were related to the respiratory events or something else like limb movements, etc. And then it goes into the respiratory, will tell you whether the patient had an average respiratory rate. For example, whether they did have central apneas or not. We all do have central apneas. Within certain amount is normal, so there's nothing to be scared about, but we report that. And then we go into the obstructive events, how many obstructive apneas and hypopneas had the person, and finally the obstructive apnea-hypopnea index that is calculated based on the sum of the obstructive apneas plus obstructive hypopneas plus mixed apneas divided by the total hour of sleep. So you come with that number. Is it the most perfect index? No. It has flaws. However, it has also strengths. One of the flaws that it has is that it counts the number of apneas, but it's not the same to me if you have an apnea that could be 10 seconds versus the next person that has back-to-back apneas of 30 or 40 seconds. Also, you need to meet certain criteria of desaturation with the hypopneas, that is 3% below your baseline. But it's not the same. Let's say you hit 3% or more and you have certain parameters in the breathing pattern, you would qualify as hypopnea. However, it's not the same if you go down from 95 to 91 versus the next person who goes from 94 to 85 all the time. So that piece doesn't get into consideration, and also the entitled CO2 doesn't get into consideration. So it's not the same if you are retaining CO2 versus someone who's not retaining CO2. But that's what gives you. So we also report the saturation, if the saturation was normal, the saturation nadir, and also that is super good to report also the percentage of time that the person spent with oxygen hemoglobin saturation less than 90. That typically would likely to be like 2% or less. I mean, that would be okay. You have little dips, but someone who is all the time with no cardiac disease, with no lung disease, it makes you wonder that it's a case of more severity. And then we also report about the ventilation. For example, if the entitled CO2 was normal, if there were periods of hypercapnia, if these were mild, moderate, severe, and they correlated with respiratory events or no. Then also we report about the heart rate. We also have an EKG during the sleep study, but it's only one lead. So it doesn't allow you to go into all details if you want, and also because many of us were not the expert EKG readers. But many times, we can say that someone is having like a blockage or things like that, and then refer them for a full EKG. Or we can send the screenshot of the EKG to the cardiologist and say, this is going on. I mean, what can we do about it? So we pick up stuff. And also then is the periodic lip movements during sleep, that when those are above 5 per hour are considered abnormal. They have to meet certain criteria. They're typically associated in children with a decreased levels of ferritin. So if that's the case, we request the referring provider to check the ferritin levels, etc., etc. So it's a very comprehensive data that we have. And eventually someone can have a seizure that is subclinical, that you could see in the EEG, and the person not necessarily is having like abnormal movements.
I was just going to ask, when you're talking about periodic limb movements, like how often do you see that? I feel like it's probably more often than people think, because I have 4 boys, and at some point they've all crawled into bed with me, and I've been definitely kicked in the face and stuff like that. So I feel like it's pretty common, more than what people think.
Yeah, it is. It's more common than what people think. I don't remember exactly the prevalence, but I would say that when we see, and most of the time, some people are referred due to that, but many times we find that someone comes for something and the study may be otherwise normal respiratory wise, and they end up having periodic movements that are a little bit elevated, and we check the ferritin and it's lower, and we treat them with iron, and they go better.
Let's say that again, we have we have a high suspicion. We send for a sleep study, and there's always a nice interpretation that the very kind sleep physician provides. But if I want to get a better understanding, what number would I look at without going really deep? Is it just the AHI? And if so, what's the cutoff in a pediatric patient where I can say you have an AHI of 2 that meets criteria, but it's slow, or low, or 14 where it's, oh my goodness, I think this is, can you kind of walk us through the really big takeaways that someone who's not a sleep medicine specialist, but who could still look at this and get some decent information to think, yes, confirmed diagnosis, or inconclusive, or, oh boy, is this OSA like?
You need to look at the obstructive apnea hypopnea index first. So typically up to 2 would be considered sort of normal. However, there's a lot of literature that if you have symptoms, you may benefit from treatment. And for that, I invite you to read the last edition of JAMA, where we published a study that is the Pediatric Adenotonsillectomy Trial for Snoring. First author Susan Redline, that was done at 7 centers in the US. It took 7 years to complete, and we randomized 460 children to early adenotonsillectomy versus a year of watchful waiting, and all of them, they had mild sleep disorder breathing, meaning an obstructive apnea hypopnea index less than 3. So you can look at that. But for this one, okay, so we need to look at that. Less than 2, I would say, okay, you can do watchful waiting if there are no other symptoms. If the child is very symptomatic, I will still refer for treatment. Then between 2 and 5 is considered mild, but the big disclaimer here that this is based on expert opinion and not necessarily on outcomes. So personally, I do think that 5 to 7, if we don't have significant desaturation and the child is otherwise normal, we could still do watchful waiting for some time and repeat the study in 6 months to a year and see where we're at before deciding treatment. Then for most people, between 5 and 10 is moderate. I think we can be a little bit more lax with that as well. But if someone has definitely, as I mentioned, 7 or more is someone that will require treatment, you will refer to ENT if they have a large tonsils or adenoids. And then greater than 10 is what is considered severe. I think it also depends what is your saturation nadir, if the person is hypoventilating, etc. Because it's not the same. For example, this may be more complex, but let's say you have an obstructive apnea hypopnea index of 6. The person is saturated down to 75, spent 5% of the time with saturation below 90 and was also hypoventilating. It's not the same that someone that has an obstructive apnea hypopnea index of 11 with a saturation nadir of 92 and never had hypoventilation.
That's such a great pearl. I feel like those have always kind of stuck me up, and I always probably put too much emphasis on the AHI, and that made so much sense of that the AHI is kind of it seems like their core part of the study.
It's the first one to look at, but then you need to look at the others. Overall, if you need to manage resources.
Talking a little bit more about some of those results we get with that sleep study, I was recalling a recent, and unfortunately this was about an adult patient, but I had a sleep provider talking about the RDI on a study. Is RDI used in children, and are there similar cutoff criteria when trying to make diagnosis of OSA?
We use the obstructive apnea hypopnea index in the in-lab attended polysomnography. Some home sleep apnea testing, that by the way, that's a different topic, the different types. Type 1 of sleep apnea testing would be the in-lab polysomnography with all the bells and whistles. Type 2 is sort of the same, but unattended at home. And that's what we use for the research that I mentioned. And then type 3 is without the EEG leads, they only have the bells. And then type 4 are others that do, for example, only pulse ox or tonometry or something else. And most of those report the RDI, which is the respiratory disturbance index, that is not necessarily the same as the obstructive hypopnea index, but it cannot be correlated one-to-one because those measurements, they don't have the same airflow measurements that we do have in the obstructive hypopnea index. So I think in adults you may see more the RDI because they do more of home sleep apnea testing.
One of the things that you would mention is trying to manage resources, and something that we're often finding in pediatric, clinics around the country is that sometimes there are disparities in how we can access care. And I think that's probably no different when it comes to accessing pediatric sleep studies. Here at the Cribsiders, we want to make sure that all children have access to care, and thinking about ways that we as pediatricians can help that mission. If you speak to maybe some of the disparities that you see around OSA, or including trying to get kids access to pediatric sleep studies.
Well, those are huge. And actually, I do have an R01 grant studying at pediatric health disparities in SDB. So I know what I wanted about it. But actually, there are groups that every minoritized group are overrepresented in sleep disorder breathing. They do have more sleep disorder breathing compared to the white counterparts, and also their severity seems to be more, and the percentage that they resolve with treatment appears to be less. And there's a myriad of hypotheses what that could be, because race or any minoritized status is a socio-ecological construct. So it depends of things like where you live, for example, the pollution that you may have, or aeroallergens that you may have due to your living condition. Your neighborhood, for example, your neighborhood is noisy or etc. You have a big light on top of from the street on top of your bedroom. It's totally different than you live in the suburbs in a farm and everything is nice and quiet and you have your own room. There are different stories there. So yes, those disparities exist. Also, the disparities to access, they exist a lot because sleep studies are expensive and many times depend on the insurance that the family have, how much they have to pay for reimbursement. And for many families, the copay that they have to do, meaning families that are not in full medical assistance, they have it harder because they may have some insurance, but actually they need to pay for higher copays than those that have better insurance. So many times they don't go to the study because they just cannot afford it. Or also they may face issues with the other kids at home. If you have several kids and you need to come with an adult, and that adult is you or the other parent or a close family member, it creates certain duress for the families. Also, you are more prone at not having a 9-to-5 job. Maybe you have a job that is some sort of service and you need to work longer hours. When I was in Philadelphia, I did see a lot of Hispanic patients that were illegal, and the parents work easily 16 hours per day, Monday to Sunday. If they work in a restaurant situation, for example, they would do 2 shifts easily. Their day off could be any day, Tuesday, Wednesday, whenever that was, and they don't have so much to say because of the situation that they live in. So yes, all those are critical.
Thank you. I appreciate it's important for kind of what we do is kind of really identifying that there are these disparities to access and treatment across every topic we talk about. And it seems like, especially when it comes to sleep quality, sleep disturbances, supports to get some of these more invasive testing, it really is exacerbated by a lot of these other health disparities that we see.
Yeah, and if you think about, for example, we're talking about bedtime routines. Let's say if you have like a job that is 9-to-5 or so, most likely you may be home at 6, everybody have dinner, you have time for the routine, it's something nice, it can be me time with the kids, etc. Let's say the same person, but you have like 2 jobs, you get at home at 10. Do you really want to go? First, you're sort of past the bedtime routine, and there are other level of stressors that exist. If you were waiting for the bus, if it's snowing, or here that it may be like very hot in the summer, and the bus doesn't come that often, immediately you have different level of things that are happening that are due to disparities. Everything takes longer to accomplish when people have less resources, and it's not because people are not smart or anything. It's just because imagine if I have to take the bus to work, it will take me like 90 minutes because I will have to walk like 30 minutes to get to the bus stop. Then I have to wait when the bus arrives, and then they stop like in every corner. It's different. Everything takes longer to get done. Going to the supermarket, etc., etc.
I think it's a really helpful reminder for us to remember where our patients are coming from.
Exactly.
And all the things that we can do to try to move care forward for our patients in so many different ways, while acknowledging that it can be really difficult for people to sometimes get access to what they need. And so thinking about our case, Cece Parker, we think, okay, she's got OSA, and now her parents are like, okay, now that we know that she has obstructive sleep apnea, what are we going to do to address this problem? So what are some of the initial treatments that we think for patients who are confirmed to have obstructive sleep apnea?
Well, typically the first line treatment recommended by the American Academy of Pediatrics is adenotonsillectomy in those that have a large tonsils and adenoids. That would be the first one. And actually it's one of the most frequent surgeries performed in the United States. I believe between 500,000 per year are performed. Also, we would like that to be done by the pediatric ENT, and it could be done in the outpatient setting most of the time, and this is where the importance of the sleep study comes here, because if a child qualifies as severe obstructive sleep apnea, it's better to have it done in the hospital setting so they can be observed in an ICU just in case something goes wrong, because it's someone who's been having these desaturations forever, so may have other complications, compared to the person that doesn't, that they can have it in the patient setting. So that would be the first line of treatment. In the case of kids who are severe, and in ideal world, everybody should have like a repeat sleep study to see whether they resolve or not. Obviously, I understand that's impractical, and if the case was mild to moderate, I would be less prone to say, oh, you totally need to have it. It would be like recommended. But if the case was severe, it matters because we want to know how much they get resolved, and also because kids who are severe many times tend to be obese, and obese kids also tend to resolve less. So in that case, we need to think about second line of treatment, and one of those is positive airway pressure, which is CPAP or BiPAP, depending on the case. That is absolutely doable in children. It takes time, like everything, and it takes the village, the family to be involved and the support that they need to do it. But they do it, and we have a lot of success with them being adherent to CPAP. There are other treatments depending on the particular situation. For example, if they have a restricted maxilla, the maxilla is too narrow, for example, from the mandible, they can have an orthodontic treatment to help with that. But most of the time is what we do.
And one of the treatment interventions that I've seen with a little bit of evidence for, I guess, mild cases is things like intranasal fluticasone, especially ones that have presumably just enlarged adenoids or inflamed adenoids. Is that something that is in practice often used or helpful? Or what are your thoughts on intranasal fluticasone? I just love the idea of treating irritability ADHD symptoms with intranasal fluticasone.
It is used more than it should. It has a role, but for example, this is a study that my mentor, who died unfortunately some years ago, had started a trial of intranasal corticosteroids versus fluticasone versus placebo in kids with obstructive sleep apnea with a range of 2 to 30 in the OHI. So I continued the study after she died, and we published it like a year and a half ago. And we didn't find differences in the main outcomes. That were all the neurobehavioral things. They were the same between the two groups. The OHI, all the stuff, they didn't change significantly between the two groups. However, what did change with fluticasone were the symptoms. The symptoms meaning of nasal congestion, for example, the nose questionnaire, the OSA 18 improvement, things like that. But the meat, if you want, the Connors rating scale from teacher, parents, or the brief that actually we're measuring executive function with that, or testing that the kids do to see where with the dexterity, like the pegboard and things like that, all that were the same between the two groups. So if you ask me, I would say it has a role. It can treat the symptoms related to the nose, or it can treat maybe snoring, but don't expect that it will treat obstructive sleep apnea.
Love it. Great pearl. And one more, you mentioned a couple of times when we were talking about diagnosis for kind of mild, moderate is watchful waiting. Can you talk a little bit about what that entails?
Yeah, that's a great question, because people think that watchful waiting is okay, bye, see you later. It's the part of watchful we're missing, right? So it implies that also the family needs to report to us how the symptoms are changing or improving within the period that we decide to watch the kid. That can be 6 months, 12 months or so. So many times we can ask the nurses working with us to give like a call to the family like every 2 months or so. We can see them like every 6 months in clinic without doing nothing and see whether things improve. Because also remember that the kids are growing, so their upper airway may be growing during that period of 6 months and 1 year, and whatever was obstructing is obstructing less. So in that case, if parents report, for example, that the symptom persists, etc., I would repeat the sleep study after 6 months to a year to see where they're at. But you could see that some kids resolve, and we learned that thanks to the childhood adenotonsillectomy trial, the CHAT study that was published in the New England Journal of Medicine in 2013, that they randomized kids with obstructive sleep apnea with an index between 2 and 30 to early adenotonsillectomy compared to watchful waiting for 7 months. And the watchful waiting and the early adenotonsillectomy both improve. And that was something new, actually, that changed practice. Now they improve more with the surgery. The watchful waiting improved less, but those that were in defense, for example, that were 4 or 5, at 7 months, some of them may be within the normal range. So that help us understand that maybe we don't need to rush. Before this study, we were sending like pretty much everybody to adenotonsillectomy, creating chaos as well, because it's more time for the OR, a lot of things that need to happen, increased cost, etc., etc. So that's the beauty of clinical research that I like a lot, because I think we can inform fastly about clinical practice.
And what other questions are about some of the oral devices, or that there is, especially in adults, these series of devices that it seems unclear if there's strong evidence for these, or dentists maybe sometimes recommend specific devices. Is that something we should be considering for our patients?
Not really, unless someone who has a narrow maxilla, I think the rapid maxillary expansion could have a role in those specific persons. But the other oral appliances haven't been well studied in children. The issue is that you have to think that anything can really affect the morphology of the face and the end of growth. So I would be very cautious to see which one could be really used in children if we do have other measures of treatment that are more effective. And also because they change so much, so it's difficult to. For example, a CPAP, it's a CPAP. It will give you positive pressure. You will extend the upper airway, so whenever I come with my pillow, your upper airway will be open. But the oral appliances, the one, for example, you and I create one, and then Crystal and Chris come up with their own oral appliances, will work differently. So,
what about, say, a Inspire implant? Have they looked at that in children?
It is approved for children with Down syndrome down to age 10, but not for typically developing children yet. Now the data, it's good, but like anything else, it's not like a miracle. For example, if they use the obstructive apnea-hypopnea index as main outcome, as they did in the first study, they showed that the average reduction was 50%. So for someone, for example, who has, an obstructive apnea-hypopnea index of 80 going to 40, yeah, it's good, but it still has significant obstructive sleep apnea. So they may need to do something else. Maybe they need less blood pressure, etc. Also required to be adjusted a little bit because, the tongue protrudes. So at the very beginning, people wake up a lot with that. It's like every so often you're doing, for the people listening and mimicking that you're protruding your tongue like a frog, like every
really
like every 1 minute. So
yeah, I was gonna say, I'm not sure how this is gonna come across.
You see, I got in the mood of the radio. Describe it, but that's what happens. And now they're doing a continuation of the first study of Inspire, and now the outcome is neurobehavioral outcomes, because basically that's what's gonna matter. Right? Not only the number. When I explain to the family the number, they have a sense, but what matters to them is how the daytime functioning would be.
I think we are reaching a point where, we're wrapping up and we're thinking about all the big things that are happening with OSA. And I think the big takeaway for me is that this can really impact the care that I provide to children and making sure that I'm, managing their OSA. And one of the questions that I have is that if I'm seeing a child in clinic who has OSA, but let's say they have an indication for some separate surgery, are there any special conversations that I need to be having either with a specialist or with the family about perioperative management for kids with OSA?
Well, if they're having a veil tonsillectomy, it's important to put it in the context. It's a surgery that is very commonly done. It does have some complications that are rare, but they do exist. For example, pain. Many times kids have pain and they cannot eat well, so they need to be in the hospital a little bit longer. They can be dehydrated due to that. Also, they can have bleeding. That most of the time can be like a little minor bleeding, but occasionally it can be a large bleeding that requires some surgical intervention. So it's important to know that. It's overall in centers that they do a lot of procedures because, it's rare, but the more you do, you will hit that. So it's important to know that.
And let's say the surgery isn't for their tonsils, and let's say it's just for any other surgery that's happening. Is there anything differently that you would do for a child who has OSA?
When you're having surgery for whatever reason and you have obstructive sleep apnea?
Correct.
Okay, well, if you were treated for your obstructive sleep apnea, you should be fine. However, in kids, for example, who use CPAP or BiPAP for obstructive sleep apnea, typically we ask them or we communicate with the physician, with the anesthesia team, and say that they should be extubated after the surgery to the CPAP or BiPAP, because anesthesia affects also the neuromotor control of the upper airway. So after you wake up from a surgery, you may not regain total control of the upper airway. You may have episode of obstruction. So it's something that we recommend.
Great. Beautiful in-hospital Pearl. This has been great. Conscious of time, I would love to ask, looking back, we've talked about everything from risk factor screening, diagnosis to various treatments. What are some of the big takeaway items that you want to make sure our listeners leave with when talking about OSA?
Yeah, it would be important for them to know that as part of the sleep history, they need to know sort of the bedtime routine, that sort of stuff that is short. Also to recognize that it's something that's really frequent and have it on the back of their mind. Maybe not everybody needs sleep study now. Overall, if you're in primary care, chances are you will see the patient again, so that allows you to buy some time to decide what is the best time to send the family for a sleep study. But it's important that they shouldn't, be too cavalier about it. Like, you're snoring, then there's nothing. Putting 2 and 2 together and think that actually it's something that can impact the life of the child long term. Because if when you're little and your executive functioning is affected and you're not learning what you should learn there, based on my own experience, what you didn't learn when you were a child, yes, it's difficult to learn it after, right? So that's the moment that we're like sponges. And the other thing, sleep is free, but it's affected by poverty.
I love that's been a core point. It makes a lot of sense.
Yeah. So it's not to take it for granted, it's really affected.
For all the listeners out there that are aspiring triple board pediatric pulmonology and sleep medicine physicians, anything that you'd like to plug, any resources that you'd like to share, or anything we should point our listeners to check out?
Yeah, the American Academy of Sleep Medicine has resources and actual grants for people who are in medical school and are thinking about a career in sleep medicine. I believe it's about $10,000 per year. They need to apply. It's on the website. And also there are opportunities for the pipeline at the level of the American Thoracic Society and the American Academy of Sleep Medicine to invite them to the conferences. There are some grant opportunities for them. They could go to the national conference, be involved in research, and just go with it. We all
awesome.
Sleep. So it's something that you should be curious about. What happens when your brain is theoretically off, but it's not really off. So that's something important. That, for me, for example, that was a big driver that I wanted to know what happened then.
Yeah, I love that. It's an amazing human thing that we all do. And so we appreciate your taking the time to kind of dive into this one tip of the iceberg of sleep. And so we'll have to have you back sometime to talk about other sleep disorders or even normal sleep. But this has been incredibly helpful. Lots of great pearls, lots of great discussions. Thank you, Ignacio, so much for coming and for joining us here on the Cribsiders.
Thank you so much.
The number you have dialed has been changed. The new number is...
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website, thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or your favorite podcast player. You can also email us at thecribsiders@gmail.com. A special thanks to our producer for this episode, Dr. Crystal Nora, our showrunner, Dr. Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. I've been Justin Lee Burke.
I've been Crystal Camtochukwu Nora.
And this has been Chris the Chi Manchu. Thank you and good night. And for those of you who've made it all the way to an end, here is another poem generated by AI. The title is Whispers in the Night. In night's embrace where children softly lie, a shadow lurks unseen, yet felt in breath. In silence deep, a struggle against a stealthy death. With tender care, the healer's art draw nigh, unveiling truths that silent lips belie. In whispered dreams, a cure takes shape beneath. Now breathe, they deep, as peaceful slumber seethe. In dreams once marred, now sings the lullaby. See you guys.